Welcome, everyone, to the third ever POCUS Journal podcast recording. We're really fortunate today to have two authors from one of our recent research studies that was published in the November 2021 issue of POCUS Journal. That's volume 6, issue 2 on POCUSjournal.com. The article is "The Use of Thoracic Ultrasound to Predict Transudative and Exudative Pleural Effusion," and we're really fortunate to have the senior author, Dr. Dbardino, on our podcast today, as well as one of the co-authors, Bastin. And without further ado, I want to ask Dave here to introduce himself, and I'll take it away.
Thanks a lot, Ben. Yeah, I'm Dave DiBardino, interventional pulmonologist at University of Pennsylvania, and was lucky to conceptualize this study with Cameron, who's on here with us, and our ultrasound guru at Penn to, really just help us sort of think through some questions that nag us on our inpatient pleural effusion service and see what ways we could push our interpretation of ultrasound to help make some clinical decisions and, further support some evidence that's been slowly accruing over the last 25 years about ultrasound in the setting of pleural effusion. So happy to see it out there and talk about it today.
Outstanding. I do want to ask you, I know that clearly interventional, pulmonology, ultrasound's one of the tools in your toolkit, but, we are an ultrasound community, and I like to ask our guests if there's a story from their training that really was like a first kiss, as some say, with ultrasound, or just showed you how crucial point of care ultrasound is in your practice, that inspire you to keep it as a tool.
Absolutely. I think that for me, it's really been, once doing pleural procedures became really a bigger part of life. So I guess in fellowship as a pulmonary critical care fellow, and then probably even more so as an interventional pulmonary fellow, the consults for pleural procedures that became more complicated, meaning chest tube consults in more complicated pleural spaces. That's really when I found the power of ultrasound to just be kind of unmatched. And that's when, having something right then and there telling you about where you are in the pleura is really just essential. So I really feel like once more complicated pleural effusion consults started coming down the line, it was really an aha moment. And I think in fellowship as a pulmonary critical care fellow, moment that always sticks out to me is really managing someone with a pneumothorax in the ICU who, probably couldn't move to IR, probably wasn't stable enough for CT guided intervention, whose surgery didn't want to touch because they may have had a loculated pneumothorax, and who was declining, and really using a lung point and really using an ultrasound right then and there to pick our spot, successfully place a pigtail. That moment really sticks out, and I'll never forget it.
Outstanding. We have a lot of trainees in our audience, and that's an inspiring recollection. Cameron, tell us a little bit about you, and just maybe if you have a first kiss moment with ultrasound when you fell in love with POCUS.
Yeah, my name's Cameron Bastin. I'm the director of POCUS for the internal medicine residency and the Palm Crit Fellowship. I'm one of the APDs for the Palm Crit Fellowship. I'm excited to talk about the study because this is one of the things that I really hoped that POCUS would find a new indication for, and I think that the results that we came up with are nice for refining that interface of a clinical decision-making model, integrating the information from POCUS without just saying, hey, this is a slam dunk. Obviously, this is something that everyone must do all the time. I'll tell you that my aha moment actually happened while I was in medical school. I was helping as a part of a team setting up a exchange program in Rwanda with the medical school in Rwanda, bringing the medical students to Philly, and then bringing Philadelphia medical students to Rwanda to set up kind of a bilateral program. And I was in the intensive care unit, and there was in their academic medical center in Butare, and there was a patient who was intubated and who they couldn't get a chest x-ray because there was no portable chest x-ray machine. In order to get a chest x-ray, they actually had to wheel the patient down a flight of stairs and across a lawn to the radiology department, which was at the time impossible because the patient was in extremis. And we were trying to think about what we could have done. And one of the doctors that was there talked about how they wished they had an ultrasound machine. They might have been able to answer the questions that they had. And then that led me to, when I went back into residency, getting as much experience as I could in the emergency medicine department, running a small lung ultrasound research project specifically to try to see if I could answer that question back in Rwanda. And then a long and winding road of further attempts to learn as much as I could about point of care ultrasound, and now to teach it to as many people as I can.
Wow, this is so much fun. I literally wish we could take the whole podcast and just talk about our backgrounds in POCUS, but I do want to make sure we have time to get into your really important research that we're so fortunate to have in our latest issue. I meant to say I'm Dr. Galen. I go by Jamie. I'm the editor-in-chief of the POCUS Journal. If I may, I wanted to just sort of set the stage for the new learners in our audience about why this is such an important topic. So, and then I'll pass it over to Dave. The background here is that pleural effusions are incredibly common, and for an interventional pulmonologist who's work in the pleural space is so routine. I think it's pretty nuanced in terms of management, and I'm really eager to hear from you about some of the pleural effusions that you decide to tap and the ones that you monitor. But for a lot of POCUS users who are just starting out in general medicine, medical students, internal medicine trainees, hospitalists, et cetera, pleural effusions are incredibly common. And one of the main questions is this pleural effusion that has to be tapped? And that may be because they're able to do the tap themselves, or who needs to be consulted as an expert on a case of unilateral, bilateral pleural effusion in terms of, could this be an exudate that's important to evaluate, by thoracentesis. And so, one of the key questions here is the lingering one, based on a point of care ultrasound. It's so sensitive for pleural fluid. We find a lot of small effusions, or they may or may not be clinically significant. And the question is, is this an exudate? And I think I agree with Cameron. It would be amazing if ultrasound could answer that question definitively for us and avoid, invasive procedure for a patient, which, although routine, as you point out in your article, does carry some risk and takes time and, is invasive. And if it was able to be ruled out as far as it was a transudate, that the management of transudates is really the underlying cause, and exudates are more interesting in terms of pathology. And so the question here, the big picture is, do I need to tap this effusion? So Dave, tell us a little bit about the background, sort of the gap in the literature that you discussed in the article, but that prompted, the study that you guys did.
Yeah. Thanks, Jimmy. Sorry I called you Ben earlier. I was just going off the Zoom handle there, but
no problem.
Yeah. I think we were wondering, there was only a few studies out there thus far. Actually, one though was recent in chest, and we were interested in trying to build the literature to say, can we predict fluid characteristics on ultrasound? I think taking your prompt maybe one step further, though, I think we had this interesting dilemma where maybe that first thoracentesis in a large effusion in someone who clearly didn't have heart failure or hepatohydrothorax was low risk enough for most people to feel comfortable. But this was all data pulled from inpatient thoracentesis service. So one thing that we always sort of would think about is, how many of these people are getting multiple procedures during their stay? And we anecdotally think, and I'd be interested to see what you think, Jamie and Cameron, but we anecdotally think that not only do patients hate multiple pleural procedures in one admission, but it's uncomfortable, carries repeat risk. And then also probably each subsequent intervention is less straightforward, as the pleural space may get soiled with blood or complicated or seeded with bacteria. So we were sort of thinking about it from the angle of, if ultrasound was a magic bullet, it could tell you transudate or exudate, that'd be the best. But let's say it can't. Are there other interesting things it can do to save someone multiple procedures in one admission? Because I think there's this nuance where if you're just kind of pulling out your, Richard Light textbook and deciding what to do, like everybody in the world with a pleural effusion that's large enough gets a thoracentesis, basically, unless it's maybe unilateral in the setting of decompensated heart failure. But, I think we know in clinical practice, boy, some of those are low risk, and we'd love to save people the risk of a pleural bleed or otherwise. So I think we were just really interested in whether or not ultrasound could give us data about honing in our plan, because one thing that I think stuck the most in our minds was the person who ended up having an exudate and probably needed a chest tube, either to evacuate the space fully, relieving symptoms, or to treat an infection. And yet, really by just opening up the book and following the instructions, that would at the minimum be 2 pleural interventions, right? A diagnostic or therapeutic tap, and then a subsequent chest tube. And we all know that subsequent chest tube is a lot easier when there's a giant pleural effusion, right? So I think we were just excited to just, thought experiment about how ultrasound could even help guide a more definitive plan. And furthermore, like, would it ever push someone to either skipping a diagnostic thoracentesis and going directly to chest tube, or again, like, could it ever just straight predict your fluid characteristics, which obviously is very tough, but was a question we thought was worth, re-examining based on just a couple of papers that were out there.
That's a great question. And before we get to Cameron's part, I just want to ask you: did you have a hypothesis that the anechoic, the simple fluid without echoes, did you have a hypothesis that would be more likely to be a transudate?
Yeah, I did. I mean, I think I was wondering how specific an anechoic space would be for a transudate. And in other words, are all exudates non-anechoic? I think was the question that we thought maybe we had a shot at showing something there. Mm-hmm. But pretty comfortable with the fact that a transudate we would expect to be pretty anechoic. Yeah.
Got it.
And Jamie, like, this question, I think we looked at it from both sides. The old data that was out there, starting with like studies from the 90s, really kind of, I think, set us up to believe that an anechoic effusion was not going to be sufficient for us to rule out exudate. We knew that from old studies, but we had this thought in our mind, and I think we all do this: oh, those were old machines. They didn't know what they were doing. They couldn't pick up on the subtleties that the newer machines could pick up on. Maybe we can get better. Maybe we can get to the point where, because I don't know about you, but I'm constantly being asked the question of, oh, does this effusion look exudative to you? And before we started looking into this, the answer was, I don't know. And the Shkolnik paper that came out in Chest just about a year before ours, we actually wasn't on the scene when we started collecting data for this. And the idea was that all we had before we started this study was these studies from the 90s that really were, it turns out, consistent with what our results ended up being, but were not so devastatingly convincing that it was like, all right, this is a solved question.
Got it. Well, I think that it gets to a question I had later, and I know you have to leave the podcast a little early, so I do want to ask you, Cameron, about what your findings are around the technical aspects here about gain and device settings or devices, and that gets to some of the inter-rater variability that you as expert readers found in your study. So maybe you could just talk a little bit about that, just to make sure we cover it, because it's such an important issue about answering that question. Does this look exudative? Walk us through what makes something look, why people think that ultrasound can help detect an exudate. What are some of the features of complexity?
Yeah, absolutely. And I think this is where it all comes down to. So we all can agree on anechoic, except that as you start increasing the gain, the subtle artifacts of an anechoic effusion start making it look a little bit brighter. And if, for example, you're working with a machine without tissue harmonic imaging, then the artifacts in the deeper space are going to be even more exaggerated. And so when you look at the original studies, those ones from the 90s, they try to categorize effusions as totally anechoic, anechoic with a little bit of haziness, loculations being present or not, or totally echoic, where it's like, you know, the purulent effusion where it almost doesn't look like fluid anymore. It almost looks like the kind of soup that will eventually come out. And we were struck by the heterogeneity, even in our institution, of image acquisition technique. And what I mean by that was there was, unfortunately, and we've tried to address this, inconsistency about exam preset using the abdominal preset versus the lung preset. There was inconsistency around depth. There was inconsistency around the use of video file storage versus still file storage. And there was inconsistency about gain. Dr. Novopanebianco and I wrote an editorial specifically about this, where we put up some examples in chest saying, hey, look, here's an effusion that looks anechoic. Here's an effusion that looks echoic, that looks like it's complex. This is the same effusion. We just changed the exam presets and saved these two clips. And I think that that's an unfortunate truth and always going to limit any retrospective study on this topic, which is really how ours and all of them, even the prospectively collected ones, unless you have a strict protocol by which you're setting exam settings, clip duration, and then a fairly structured means of interpretation as opposed to just expert gestalt, or then it's going to be hard to find any improved accuracy over what we describe, which is well within the confidence intervals of what's described in that chest piece from the year before, which is actually within the confidence intervals of what's described from those pieces in the 90s.
Getting back to the paper, you know, I think it'd be great if for our listeners, if Dave, if you could just sort of summarize those findings. So, you know, Cameron outlined that, you know, complexity goes from anechoic, you know, you graded that as 0, and then increased echogenicity, but without septations, was sort of grade 1. Grade 2 was, this is in figure 1 in the paper, was complex with septations. And then there were very few, I think only one homogeneously echogenic, you know, imaging in the study, but this is sort of the grading scale. And then what did you find in you know, in the study design you had where your reviewers were blinded to the knowledge of whether it was transudative or exudative? You reviewed these you know, the procedure service thoras retrospectively, and assigned these scales, and then looked to see whether the ultrasound findings could predict, you know, transudative or exudative in a variety of conditions. Just tell us the sort of summary of the findings there.
Sure. So, you know, we were exclusive to patients who had all the lab follow-up. So we had 237 thoracenteses in this couple-year period that had imaging in our database to review, but only 166 with all the lab criteria. So that from the get-go, kind of keep that in mind, and that some transudative patients who probably had heart failure with just therapeutic taps may have been kind of excluded. So we probably were shunted more toward the exudative malignant population, but still had over 150 cases. And we had about half the patients in the study with cancer, but still a good amount, about 20% with kind of those classic transudative conditions, at least by history, heart failure and liver failure. However, as we'll find out in a minute, that didn't necessarily predict the fluid characteristics all that well. So kind of breaking it down by the ultrasound classification, this is figure 3. You know, as you can see, there's really a whole lot of exudates that have all of the ultrasound grades. And you know, on that note, the ultrasound graded out with good, you know, good agreement. You know, we had a kappa 0.75 between just 2 experts blinded. We did have a third expert sort of tiebreaker on disagreements, but you know, I think Cameron noted that kappa goes down with just still images, went down to 0.67, and then went up to over 0.8. So kind of near perfect agreement when it was videos. So and that's without any standardization of the gain, clip duration, machine being used. So even just that one simple thing, you can see, to Cameron's point, how big of an impact it is. But nonetheless, we really just had really the exudates kind of dominate as a heterogeneous ultrasound group. I think 88, it looks like, of the 124. So the vast majority of exudates were anechoic.
Right.
So I think that's right from the get-go in line with old data, and then the one more recent paper, and that if you clinically think something needs diagnostic thoracentesis and it's anechoic, that really shouldn't dissuade you from a thoracentesis.
Right. I think that to your point about the study population, without even analyzing it further, given that half of the, based on characteristics were included malignancy, it wouldn't be surprising that such a large number of the effusions were exudative. I guess the question I had, you mentioned heart failure and hepatic hydrothorax were smaller numbers, included, and that's obviously by virtue of who they're consulting you on, meaning someone is bilateral pleural effusions on the medicine service. I assume they don't call interventional pulmonary for a TAP if they're small or moderate and they're diuresing them and they're getting better. But I guess the question I had is, what is the importance of finding an exudate in someone with heart failure? I mean, I think sometimes these TAPs are done therapeutically, like you said. Was it sometimes that they were unilateral and there was a possibility someone thought there could be malignant involvement? Is it significant to find an exudate that's a borderline exudate? I think you guys talked about in your paper is what I call a trixudate, where you have an exudate that is really just a transudate that's been sitting around for a while, and then either because of diuresis or other sitting around, it's a sort of borderline by Light's criteria. But were these exudates that you found in heart failure patients, they're not high grade exudates or 3 out of 3 Light's criteria? They're sort of borderline. Is there any clinical significance there, or is this I guess that's the question I'm asking.
Cameron, were you going to speak up? Go ahead.
Yeah, just real quick, because then I'll probably go. You're asking a really good question. I mean, Light's criteria is intended to maximize sensitivity, and clearly, as you diurese someone and a pleural effusion starts to decrease, it's likely to end up with at least one of the 3 Light's criteria positive. It meets exudative criteria, even though the etiology remains heart failure. The thing that I think is important is that, especially in our population with a huge number of immunosuppressed patients, the likelihood of 2 conditions happening simultaneously is high. So it's less that an exudate makes us think, oh, we need to work this up further, and more that a transudate lets us relax into the setting of, oh, this is unlikely to be a parapneumonic contamination of an already existing pleural effusion. And so I think of it as always, the clinical question we're asking and how the post-test probability is going to modify that. And this is particularly relevant given what Dave just told you about our population, which is almost identical to the other study, which is that there is a predominance of exudates in our study, like almost 80%, which is true in the chest paper as well, which is true in most of these, because, as you said, Jamie, if there's a bilateral effusion that you're very confident clinically is unlikely to need additional pleural interventions, there's not a need for a diagnostic thoracentesis. There's just a need to treat the underlying cause through diuresis or whatever it is, management of their decompensated cirrhosis. But yeah, I love the teaching that can surround a unilateral effusion in the setting of heart failure with that infiltrate on chest x-ray that may or may not be a new pneumonia, or it could just be the atelectatic lung overlying the effusion.
Great. Well, Cameron, right before we let you go, and I'm going to ask Dave some more questions about the study, what do you think are sort of the next steps here? I mean, finding that we can't rule out a, using ultrasound, we can't rule out an exudate. What do you think, are sort of the next big moves for the field?
I feel badly saying this because I'm such a technophile, but I think we haven't closed the door on ultrasound. We just closed the door on simple B mode imaging to be able to distinguish these processes. But I love spectral Doppler or color Doppler evaluation of the pleura itself to see whether blood flow suggests inflammation. I love the idea of tissue harmonics. I love the idea of additional technological add-ins to change our pre and post-test probability here. I just think we no longer need to do a bunch of big studies on, hey, is this picture transudative or exudative? Now we start getting into the, all right, what else can we ask the ultrasound to help not just one way or the other?
Great. Cameron, thank you so much for your time. Really appreciate it. Dave, if you have a few more minutes, we'll have a few more questions for you. I think that, as an interventional pulmonologist, it's so great to have your insight into this because, like I said, most of our audience is, variety in emergency medicine, general critical care, hospital medicine. They don't have your expertise in this arena. So, a few questions about the sort of technique here. I know Cameron mentioned the some of the exams are not standardized, but just as a general thing, not even manufacturers, I wanted to know a little bit about sort of the devices used in the study. Are these handhelds? Are they a cart-based machine? And and sort of how you do the thoras? Are they done with a safety synthesis type of drainage kit, pigtail drain, or that kind of thing?
Yeah, sure. So we use the Sonocyte export image machine. So this is a wheeled, very modern machine that was transmitting images directly to our, kind of online HIPAA protected database that is kept from the procedure service so that we can do things like this. So in some senses, it's like a real world example of how standardized imaging acquisition is when you're not regulating. This is kind of, not that this requires a research study, but still, I think it's just an interesting little pearl that this is kind of what happens when you take a group of people who are considered trained in ultrasound, competent to do procedures with indirect supervision. So this could be like a fellow or resident, upper level resident, and you give them a high quality machine that can do a ton, and you tell them to go for it. And then you say, we want to standardize it. Here are a few things. But then there's no supervision. You can see it's not foolproof, so we do have kind of this quality-based institutional charge that you're going to capture a clip, and you're going to do it with, some training in how to gain appropriately. And you're going to do it on automatic thoracic windowing. But even still, some of the patients in nav clips,
right,
we did see overgain, so it's tough, but yeah, these are sort of high quality modern machines. We use a safety synthesis kit, 6 French, catheter over the needle, same thing you'd use for probably a paracentesis. And, I would say we don't have any standardized method of avoiding intercostal vasculature that's necessarily mandated, but most of the people performing these procedures do have interest in some training and doing intercostal artery, Doppler and stuff. But for the most part, really just using the physical exam to try to stay 8 to 10 centimeters lateral from the spine, having kind of that lateral posterior chest or even mid-axillary area as our preferred sites.
Got it. One other technical question. Do you ever do just diagnostic with essentially an FNA with a needle, or are these always, the catheter drainage, as long as you're there, you drain it?
Yeah, great question. I think that it may not be, I don't feel very, very strongly about this, but I just say for standardization, the thought is the safety synthesis kit's small. It's a small catheter. It's very safe. And we're doing the procedure on people who already have a effusion we think is drainable, by this sort of indirect supervision model of APPs and fellows and residents. And if you're going to drain it, I think using the same procedure every single time is where we land. There can be some nuance to that, quote unquote, just diag thora. Such as which needle do you choose? Well, if you're choosing a really small needle, Is it very clunky to suction off a small needle on a 60 cc syringe? Is it going to crush your hand muscles? Because it's so clunky, are you sort of sliding in and out of the pleural, and is your needle depth actually regulated? And I think when push comes to shove, it's probably better just to pick one catheter over needle kit for all your procedures and just train everyone the same way. I mean, you know, I personally have some experience with a UE needle, which you guys may have seen. It's a 5 French catheter over the needle that's got a very, very nice sharp bevel. Something like that would be just as, you know, reasonable. But I think if you start just letting people do sort of needle on syringe drainages, it just becomes a little awkward, both physically and then really just sort of ensuring quality.
Right.
Does that make sense?
Definitely. That I really appreciate the answer. Some of these are you know, inquiries in my own practice that I, you know, like to ask people about, because there's a variety of opinions. It's I think really helpful for our audience to you know, have some take homes about some of your findings. And again, just to summarize it, you know, I think the surprise I saw was that even with the study population, as we described already, you know, that a lot of the anechoic effusions were exudates. You know, if you'd asked me before the study, I would have said that the anechoic effusions would be more likely, you know, to be a transudate, but that's keeping in mind that, you know, almost half of them had malignancy that was known before the TAP, but that it doesn't appear that there are any surprises on the higher end of complexity. That there's one homogeneously echogenic you know, effusion that's an exudate, not surprisingly, but the presence of complexity or complex septation, you know, is also more likely to be an exudate, and that I think, you know, reproduces some of the findings of earlier studies, as you mentioned. The take home I'm wondering is, you know, for sort of the non-proceduralists or non-pulmonologists, even, you know, who do you want to be called about, or who should have an expert consultation? Should all you know, concerns for complexity be evaluated by you know, for the possibility of thora, and you know, did this study sort of change who you think you should be called about?
Yeah, great question. So let me, how do I walk through some of the results, and then I'll get back to those questions. Totally. So yeah, bottom line, because the anechoic ultrasounds were majority exudate, it kind of threw off any possibility of getting a, you know, a likelihood ratio or a positive predictive value that was going to be significant for anything on the fluid characteristics. So we can't predict fluid characteristics on an ultrasound alone at the low end, on the anechoic end. So I think that's confirmatory, especially in this unregulated B mode ultrasound world, like clinical world that we sort of lived in this study. But I think some other kind of cool things are the findings, you know, getting back to what you asked earlier. So there were 33 people with either heart failure or hepatohydrothorax, where at the end of the admission, it was thought their effusion was in fact from those conditions.
Right.
And almost half of them were exudates. So, you know, I think the significance of that, which is kind of what you asked me before,
right,
is probably low. I mean, I don't think finding a trixidate, if you will, as you could use your term, Jamie, does really mean there's some underlying bad undiagnosed disease. I think we have to take sort of soft exudates, if you will, in the clinical context, and maybe not forget about them, but I don't think you need to sort of reinvent the wheel just because you're picking up a soft exudate in a transudative clinical context. So we sort of saw that, and anecdotally, just doing this for a living and doing a lot of outpatient thoracenteses that we do in our clinic, we see this all the time.
Yeah.
And then on the flip side, 10% of the cancers, confirmed cancer malignant effusions, were transudative. So on the flip side, you know, yes, 90% of malignant effusions are exudative, but you know, you can't just completely write off a clinical context if it's a transudate either. So clinical context means everything. You know, I think the part that excited me the most, which gets at your question, is I really would love this study to be a platform for people to call us if they think someone might need a chest tube at admission. And can we save someone that inevitable conundrum of they have a thoracentesis when they probably when they probably are going to need a chest tube.
Mhm.
That thoracentesis sort of drains out all of that free-flowing fluid that was that perfect buffer for a chest tube, ultrasound guided chest tube. Then we're coming in later that day or the next day being asked to place a chest tube, and now the pleural space is very complex and we have to
Harder.
do either
Yeah.
an open tube thoracostomy, defer to surgical debridement, or even just simply wait to see if the fluid comes back. And I think for me, you know, once you get to those higher complexity scores, especially the septated score,
Yeah.
where sort of 16 of the 18 were exudative, and probably a large number of those didn't really get perfect drainage on a simple thoracentesis. You know, can we save somebody a thoracentesis and therefore make their single pleural procedure safer and easier? You know, because honestly, Jamie, like if you're talking about a single small bore chest tube with maybe intrapleural lytics versus a thoracentesis followed by 24 to 48 hours of not really knowing what to do, which ends in either some complicated open tube thoracostomy or a surgical debridement, I'll take the 16 French ultrasound guided chest tube with pleural lytics any day. And I'm sure all my patients would too. So, you know, when this study was being conceived and sort of we were thinking about this and started seeing the results, I can even remember so vividly, I'm on consults for interventional pulmonary and someone had the wherewithal, they got a consult about thoracentesis. So this could be sort of for the listeners, it was septated, albeit it was large and clearly, you know, a practitioner who has sort of indirect supervision would have been fine doing it. But they decided right before doing a thoracentesis, hey, is this a good chest tube case? Should we just skip the thoracentesis given the septated nature, the possibility of infection? And I said, you know what? Yeah, why don't we try? I mean, we put a small, I think a 14 French pigtail catheter in, which was incredibly straightforward because the effusion was still large with ultrasound guidance. And over the course of 2 or 3 days with the assistance of some low dose TPA alteplase, we fully evacuated this large loculated effusion. Chest tube came out, and we ended up diagnosing the patient with actually lung cancer, even though we initially were thinking maybe it was infected pleural space. And really, it was such a great outcome for the patient. She was diagnosed, her symptoms resolved, and her lung fully re-expanded, and her pleural space was cleaned up, all through one procedure. You know, and I think that's where it's worth a call, you know, to another, or if you're, you know, independent in small bore chest tube placement, even just making that decision with or without a curbside to a consultant to say, you know, hey, do I just put a small bore tube in this because it looks kind of complicated and I'm wondering if this is infection or cancer, and whether I'm going to adequately do this in one thoracentesis. So that's where I think we can start to have a foundation, you know, for jumping directly to small bore chest tube placement. To get back to sort of my final comment, you know, where could we go from here? You know, I think like Cameron covered the technological things that could be, you know, gone into next, which I love. But for the ultrasound community, I think this is a decent platform to say, could we build some of this information into a clinical algorithm and report the outcomes using ultrasound characteristics to decide how to initially intervene on a pleural effusion? Probably not, do I do a thoracentesis or do I not? But maybe do I try to jump directly to a small bore chest tube initially or not? And I think people eager in you know, defining POCUS for kind of clinical algorithms, I think would have a little bit of a stage for something like that.
That's really, really helpful. And just to make sure I follow and summarize for some of our listeners, the question of, if there's a clinical concern for the type of complexity you're referring to of an exudate being infection, or whether if a future pleural procedure might be required, it's a good idea to involve, if you have interventional pulmonary at your institution, or if you're the primary team, to consider pulmonary evaluation for that drainage, because saving a patient an extra procedure is probably in everyone's best interest. And like you said, if you had a patient with the potential for a transudate clinically, like heart failure or renal failure or liver failure, and there's complexity in the effusion, the study wouldn't definitively say that it's going to be an exudate. It could still be a transudate, but if you were to put in a small bore chest tube and drain it, and then it resulted as a transudate, the chest tube comes out and it's sort of a prolonged thora more than it doesn't add further complexity to have just done the chest tube up front. So I think that's actually a sort of a clinical judgment that's made by the team. And from my perspective, I've seen that decision be made, like other, clinical decisions based on sort of experience and other factors like coagulopathy, and a lot else goes into the clinical decision about how to technically drain this. But I think that does point to a future direction of studying specific populations. So if it's the patient with sepsis, or if it's with a high likelihood of an infection, or if it's the patient with malignancy, or specific subsets of patients, I think that does need further study, to drive guidelines or clinical algorithms.
Yeah, and remember, just one quick thing to add to that, great summary, but really, I even as someone that is constantly being asked to do procedures in more complicated pleural spaces, the reason why skipping a thoracentesis is so nice is if someone is going to need a chest tube, to have a large pleural effusion for ultrasound guided chest tube placement is really the safest way to go. So it's all about making that single procedure safe and easy, and then that's where I think people really can miss an opportunity, because they can take a complicated septated effusion, which is high enough volume that an ultrasound guided procedure is very safe, and turn that pleural space into a small, sort of thick and complicated, small to moderate effusion with septation, making the ultrasound very difficult to interpret, making the window for a Seldinger technique procedure very small. And now that's when things really start to get sort of hairy.
Got it. It's a save some fluid for the interventional pulmonologist is my take home. It reminds me, back in the old days, they used to say, don't drain it dry in case someone has to do a pleural biopsy. It's better to have a little fluid there, but that's a whole other talk for a different time, I suppose. But save a little fluid for you. David, I really appreciate your time today. Again, the study in the latest issue of POCUS Journal is the use of thoracic ultrasound to predict transudative and exudative pleural effusion by Peter Evans et al. And we're so fortunate to have the senior author from UPenn here with us today to discuss some of the issues and the big picture and the small fluid picture of pleural effusions. This is really terrific, and thank you so much for your time.
Thanks a lot, Jamie. Let me know if you have any other questions.